Thank you, everybody. It's, as always, a pleasure to be here. Aloha kako ali, for those of you from Palau, Rananim, for those of you from Chuk, Yakwe Komaolep, for those of you from the Marshall Islands, and Hafade, if there's any Chamorros in the room. But, Whitman College is in Walla Walla, Washington, not Walla Walla, Virginia. I had to close. But I just want to say thank you, and Angela, thank you for that introduction. That was a very generous introduction. The topic for today that I was assigned is Micronesian health, and talking about Hansen's disease and STDs and radiation, and it's a very, very wide topic. So I was looking across my PowerPoints, and I have over 300 slides covering different aspects of it, and of course that's impossible. So what I thought I would do, which would I think be most helpful to everybody, is frame the topic itself. And one is talk about the Micronesians, who they are, what this compact is, why there's a compact impact. And the second part of it is really framing why there's so many medical issues. And then open up the discussion and really talk about some of the particulars. So if some of you want to know about radiation and those effects, and I see Vicky Shambo from PHRI in here, and we worked for 10 years on the radiation effects of the people in the Marshall Islands, and I have folks in my clinic that have Hansen's disease and tuberculosis and the specifics. But I think if we don't frame that, getting down into the weeds first, I think we're going to lose a lot. So again, allow me to kind of create a frame of compact, who the Micronesians are, because I think when you hear the word Micronesian, a lot of people who are Micronesian will actually tell you, no, I'm not Micronesian. And a lot of people you call Micronesian aren't Micronesian. So who are we talking about and what that all means, and then we can go into some of the details. So we'll proceed that way, if that's okay.
Okay. It's okay with heavy.
So the objective is, the reason that the Micronesians are here is because there's a compact of free association. So we're going to talk about what that is, what that says, and why it's so important for you to know what it is and what it says. We're going to talk about the compact impact. So some of the things that the compact created were very good, and with everything, there's always things that happen with treaties. The compact is a treaty that go wrong. And so when they talk about the compact impact, it's things that people didn't foresee or foresaw but didn't address it. So that's why we're all in this room. We're going to talk about basic health Hawaii, how the state is addressing that or not trying to address that. We're going to talk about who does it affect, and what are the healthcare and policy implications for you as case managers, health workers, social workers, and as you deal with this. Because I think if you don't have a framework for working with a compact, it's hard to know how to work with the people that you're working with every day in a very important way, whether it's with car seats or anything else. So Micronesian, the history. Micronesian is really a geocultural term. All of Micronesia, if you push it together, is equal to the total area of the United States. So it's a very big area. But the landmass, if you just got the landmass, it's equal to about Rhode Island. So it's spread over a large area. When they say Micronesia, it's not only Marshallese. It's Marshallese, it's Pohnpeians, it's Yapese, it's Palauans, it's Chukis, Croatians, Northern Mariana folks from Guam are Micronesian, folks from Nauru, which is not even U.S., are Micronesian, folks from Kiribati, which used to be the Gilbert Islands. Those are all Micronesian. So when you say Micronesian, if you're talking to a Micronesian, you sort of have to know how it divides up. And being a physician, I see, that they'll tell me, because I have, some language come out of Marshallese. They'll say, oh, there's a Micronesian here. Can you go take care of it? And I go into the room and it's a Pohnpeian. I don't know Pohnpeian. But so again, the point is Micronesia is a wide area. Usually when we in Hawaii talk about Micronesians and the compact impact, it's really about the biggest groups are from the Republic of the Marshall Islands, so the Marshallese, as was mentioned earlier when you mentioned about the car seats, and the people from the FSM, specifically Chuuk. So Chuuk, one of the states in the Federal States of Micronesia, and the Marshallese have the biggest representation. There's, of course, people here from Palau, and I know that I see Davis here from Palau and others, but the biggest, when people talk about compact impact, it's truly Chuuk and the Marshalls. And in fact, I can tell you, when people say, let's say you're talking to someone from Palau or Guam, and you say, oh, you know those Micronesians, you can see what that does to them. They're going to go, I'm not a problem in the compact impact. That's not, I am Micronesian. In fact, I was at a McDonald's, and there was a Palauan. By now I can tell who's from Palau and so forth. I said, oh, Palauan from Micronesia. I'm not Micronesian, I'm Palauan. So my point is that it's identifying. It's kind of like if you call a Samoan a Tongan and vice versa before you get punched out. It's that level of understanding their identities. And so this is the map and of we're talking about. So this is the Republic of the Marshall Islands, Federated States of Micronesia, a Republic of Palau, here's Guam, Northern Marianas, Nauru, and Kiribati. So when someone talks about the geographic, Micronesia, it's actually all this area right here. And the U.S. parts are only this, and this, and this, and the parts from the compact impact are really Chuuk and the Marshall Islands have the biggest part of the compact impact. So again, it's just a cultural sensitivity and a geographic sensitivity of who we are addressing and why. So how did this all come about? How did this compact come about? Micronesia in general has been under colonial rule for 400 years. Everybody loves the Pacific. There's French Polynesia, the British took over Australia, and a lot of the British Commonwealth, Western Samoa, and so forth and so on. So everybody has colonized and found the Pacific and then claimed it under their flag. And so Spain in 1500, and Germany in the 1860s, and Japan at the end of World War II. The United States, after World War II, a lot of the Micronesian countries went under a United States trusteeship, and the U.S. said, we want these guys. And the reason that we wanted them was for military reasons. In those days, the war was fought in a certain way, so it was an advantage to have Micronesia. You saw on the map that they would command a large part of the Pacific. In fact, when the Japanese took over, the reason they took over was to create a wall in the Pacific. So we wanted them. We wanted Micronesia, so we took them over. And these areas became what's called the trust territory of the Pacific Islands. So, and we called it the strategic trust. And strategic because it was a strategy. It was a military strategy. We wanted these areas for military, and it was under the United Nations Security Council. So the United States says, we're going to take these areas that I just described, and it's going to be under our trusteeship, and we will take care of them. The promise when you take on a trusteeship is you're supposed to take care of their health, education, and welfare. So the United States began setting up military bases. So Kwajalein, which is the biggest, a very big military base, that's actually one of the bases for the Strategic Defense Initiative, is in the Marshall Islands. And we began our nuclear testing in the Marshall Islands even before we actually had the rights to the trust in these areas. So we began nuclear testing in the Marshalls before there was actually a signed trust. We assumed that it would come to us. And the trusteeship's main agreement was economic development and self-reliance of the trust. So Marshalls, FSM, Palau, our agreement was we'll develop you so you can be economically self-efficient and develop. And that was the agreement to the United Nations Security Council and to these countries. And so this is a picture in the Marshall Islands of one of the lagoons in that area. So in 1960, so all of this happened, remember the war ended in 1946. In 1960, the United Nations looked at the trust and they said, and they heavily criticized the U.S. government. They said, you're not preparing Micronesia for self-government, and you're not making it independent or so economically self-reliant. So in the mid-60s, the United States poured in financial assistance to the trusteeship. They increased it by tenfold. They poured in Peace Corps. And the Peace Corps in the Marshall Islands at that time was to the degree per capita was heavier than any place in the world. And actually, there's something called the Solomon Papers, where and those of you, conspiracy theories and this and that, but there's actually something called the Solomon Papers, and it was a paper that the United States put together how to keep these areas dependent on the U.S. It's a very kind of interesting kind of situation, but there is that kind of relationship. We need them, and so, how do you do that? And so federal and education programs started, and a large contingent of Peace Corps went out there. And then at that time, public high schools see its first graduates, and there was an increase in the college bound from the areas that we spoke about in Micronesia. In 1977, we turned to these areas and said, for self-determination reasons, and because of the agreements with the United Nations, do you Northern Marianas, Palau, Marshall Islands, Chuuk, Yap, Koshai, and Pohnpei want to have self-determination? What do you want to do and organize? And at that time, they looked at all of Micronesia and they thought they'd come in as one country. It was called the Congress of Micronesia, and they said, we're going to settle this together. But what happened is the Northern Marianas, which is Saipan and the Commonwealth, now the Commonwealth, said, you know what, for self-determination, we want to become a Commonwealth. It's like Puerto Rico is a Commonwealth. Then Palau and the Marshall Islands and the Federal States of Micronesia said, we want to be independent as freely associated states. So all of these trusts formed different things, and not only did they not stay together, Palau did its thing, Marshall Islands did its thing, Pohnpei, Yap, Koshai, and Pohnpei got together, formed the Federal States of Micronesia and Chuuk, and said, we're going to become the Federal States of Micronesia. So the Congress, the Micronesian Congress, split up, and they became different things. And the U.S. Trust territory was the last of all U.S. United Nations trusteeships. So the Commonwealth, like Puerto Rico, is a Commonwealth. Guam and American Samoa are territories like the Virgin Islands. So those places, the people from American Samoa, the people from Guam, and the people from the Commonwealth of Northern Marianas carry United States passports. They don't have all the rights for United States citizens, but you'll see their passports, a U.S. passport. The people from the freely associated states, Palau, Marshall Islands, and Federal States of Micronesia, they have their own passports. So you see a Marshallese passport, you're going to see a Federal States of Micronesia passport, and so they have a different relationship. And that relationship that they have is defined by the Compact of Free Association. It's a treaty, and that's all the compact means, it's a treaty. And the treaty provides economic provisions, federal grants, political relationships, and military relationships. The compact with the Federal States of Micronesia, where Chuuk is, and Pohnpei and Yap, and the RMI, where the Marshallese are, was first established in 1986, went to 2001. Before that, these were territories of the United States. And now we're into what's called the second or amended compact, which goes from 2003 to 2023. And we'll talk more about that later. The Republic Island of Palau has a different cycle, and so they're settling their compact right now. And so when they say Compact 1, first 15 years, Compact 2 is where they're at now, or sometimes called the amended compact. And so when we talk about Micronesia, peoples from a geographic region, peoples from the Federal States of Micronesia, these four areas, Yap, Koshai, Chuuk, and some people say, oh, only these folks are Micronesian because it's a Federal States of Micronesia. But they are Micronesian, in a map kind of cultural, but they're also Micronesian because they're from the Federal States of Micronesia. So again, terminology. People from U.S. Micronesia, again, all these, and this is more of a geographic designation. Now, the compact objectives that were set out, I told about self-reliance and those kinds of things. And then, of course, the United States General Accounting Office. Now, this is U.S. federal government. In 2003, and said, you know what? The goals that were set out by the compact failed. Didn't work. And the main one that didn't work was the ability to be self-reliant. And so they don't have the economic wherewithal right now, which was what we were supposed to help them with. And so they're in troubled waters that way. And so that's why the compact's so important in one way. And then in 2006, looking at the second compact that's come in to try to bridge that, they said, you know what, it's not going to be possible to make them self-reliant. So you can see already the history of why it gets fairly messy. When they're United Nations trusteeship, it was one of, we'll take care of you, we'll help you become self-reliant. Compact one, you know what, this didn't work. Second amended compact, you know what, it's not going to work. And so it's one where, how does this play out? And you'll see how it plays out. And that's why you have a lot of work in the work that you're doing, and that's why I'm framing this historical perspective. And so the compact objectives, one was the United States wanted these countries to be freely associated states and not completely independent. So if you have Japan or the Philippines or Korea or any truly independent country, they have total rights over their military airspace and who they negotiate with and so forth. The freely associated states do not have that. The United States has the total call, it's called a U.S. strategic denial over anything military. So they have some economic provisions that they can trade with, but let's say if they want to have Pakistan or China or Japan come into the Marshall Islands water, the United States has to bless that. No other country has that kind of relationship. They kind of are independent. So it's a very interesting kind of relationship, and that's why it's called a freely associated state. You're independent as a vote in the United Nations, but you're truly not independent. You're not militarily independent. You don't have that. And then there's military base and so forth. And then we talked about the nuclear testing issues, which came about, created a lot of radiation problems, and we'll talk about that as we go on. So we talked about the freely associated states are sovereign except for military matters. But what it does do, the quid pro quo, is they said, as compact nations, we will have oversight of all the military stuff. But what we will do is you people from the freely associated states, you can go back and forth however you like. You don't need a visa. You don't need a green card. You don't need any of that, because you are letting us do the testing. You're letting us have these plans. So again, a quid pro quo is like no other foreign country has this. You can come back and forth. That's why they're coming back and forth. Get on the plane, work. They don't need a work permit, anything. They can work at McDonald's. They can work in the hospital. They can become physicians. They don't need labor certification. And there's no limitation of stay. Whereas every other country, on your visa, there's a limitation of stay. But they carry their own passports, and so forth. Whereas American Samoa and others, the place I told you, carry American passports. So the compact is a political negotiation and treaty. The primary intent was economic development and self-reliance, which didn't work out real well. So the consequences, the unintended consequences, is when you don't develop the economy and health systems don't work and education systems don't work, then what happens? Where do the people go who can migrate freely? They will go to the areas that has that. That's here. That's Guam. That's California. So when you see that big influx of people who speak Chuukese and Marshallese and all these different things, and they seem to be unprepared, it's one, maybe part of the story is who was supposed to help prepare them didn't help prepare them. And you saw what the United States GAO report said. The whole self-reliance thing is not economically, we don't know how we're going to do this, and it hasn't worked out, and it's probably not going to really work out in the way we know it in Western economics. So it's created this dimension of people moving for opportunity, like all people do, but it's one that they're coming unprepared, and then it becomes an issue that you can see. And one of the things when I actually asked about federal funding and so forth and why there's not, it's really interesting. When the compact was negotiated, and this is an important point to frame what you're looking at. When the compact was negotiated, it wasn't negotiated out of well, how much do you need, Marshall Islands, for education to come up to standard? How much do you need for healthcare to come up to standard? How much do you need for economic self-reliance? It wasn't like that. How it was negotiated was, it was like a car deal. The United States is going to get the best deal it can. The Marshall Islands is going to get the best deal it can. Palau is going to get the best deal it can. And you're negotiating. It's a hard negotiation. But the problem is, you can see that's not an even playing field. You know, it can't possibly be, there's no cards on one side. And so when it was negotiated, there were no standards articulated. So it didn't say we're going to bring the Marshall Islands to U.S. standard of care or close to it. It didn't say we're going to do that for Palau or anyplace else. What it said is, we're going to give you some money to help education and health. But nobody, and we know as health workers and you're as case managers, you have to kind of know where you're going. Nobody did that. Nobody said, well, if we give them X amount of money for health care and education for these many years, what's going to happen? Nobody studied that. It's a first error, and in planning, and you guys as social workers and case managers and the manager teams know that if you don't know where you're going, you're not going to know how to get there. So my point is that there wasn't enough money in it or planning because nobody did it. Nobody did it. I'm not pointing one way. Nobody did it on either side. Everybody thought money's going to rain from, and if they looked at the kind of money they were giving to these areas, they said, oh, there's going to be plenty of money. The U.S. said that, and these countries said that. They said, oh, there's going to be plenty of money. The only people that really didn't say that was Palau. And they negotiated hard, and that's a whole other story. And they came in playing hardball, and actually 2 of their presidents got shot or committed suicide. But it was just one of these things that, believe me, this was a hardball game. This was not, and I'm not saying somebody from over here shot him. That's not my point. It was just stating that it was a hard negotiation. People took a stance, and it was a very difficult time in history and so forth. And so, so that's what the compact is. And then, so the compact, one of the things that happened when the compact was, and this goes to show you how this then plays out in the work, again, you have to do. When the compact was signed, the first one in 1986, remember they could migrate back and forth. And when they came here, they were allowed to be on Medicaid. They could get on food stamps. So it alleviated, the federal government said, you can come, you're part of the brethren. We told you, come on in. And we'll cover you with food stamps when you need it, and you can become part of Medicaid. Then in 1996, the United States made them non-qualified aliens by the signing of an administrative pen. It was one side that agreed to this. The compact nations had no say in it. And what they said is, you're off the table. No Medicaid, no food stamps, no assistance. There was no discussion. So you can see how this again plays out. 1986, compact signed, the assumption, if we go back and forth and we need Medicaid, we need, those kinds of services, we'll get it. And then 10 years later, before the compact, first compact's finished, you're off the books. Sorry. And so what that did is, you can see, how this thing works. That was federal Medicaid. So then the states had to jump in. So then there's state Quest programs, there's state Medicare programs. So the states go, oh, now there's no federal support. The states have to jump in and take care of business because the federal government said, this compact stuff is not on our books anymore. And so they began to do that. And now, as you can see, if you fast forward, what is the state saying? Can't afford this. It's a federal problem. The federal guys are saying, no, it's a state problem. And now both people say, hey, you know what? It's a compact folks problem. And so everybody's doing this. You as case managers and social workers are all stuck with the problem. And, everybody's obviously trying to work it out. So you can see how it's a very difficult problem, and to frame it in a historical perspective sort of gives you the whys and the hows and why this is so politically charged, financially charged, and the people who get hurt are the migrants. So it's one of those things that you just feel through this a little bit. And then, so the compact structure, one of the things about the compact structure, remember I mentioned that the compact 2 is going to 2023. And a lot of people say, well, at least the compact is going to 2023. But let me tell you about the funding. Remember I mentioned to you that the compact funding is not very much. And I have a slide later on, and I don't know if we'll get to it. But just to show you for health services how little it is, in the United States, we spend about $8,000 per person per capita for health care in the United States. That's a Medicare figure. That's a real figure. that, for public health sector to take care of Americans, about $8,000 per person per year. Through the compact, Chuuk gets $128 per person per year. The Marshall Islands is about $235. Palau is about $600. So you can see 8,000, 128. How are you going to build a health system like that? And so when a lot of the workers say, well, how come you come up with so much diabetes and Hansen's disease and you have all these different things, there might be a rhyme and reason for that. And obviously I'm making it fairly being simplistic, but maybe that's part of the reason. And that also speaks to the thing about the standards and not understanding where you're going with the compact. And then, of course, what we're talking about is compact impact and the unintended consequences of a non-plan. And the other way the compact structure, so already it has not enough money in it, at least from the side of building a standard of care that matches or is even close to ours. So, that's not going to happen. And then also without enough funding, they don't have the economic machine that will keep it self-sustainable. And what's happening with the compact, the idea of the compact also is that as the compact goes on, they are going to decrease the amount of compact monies that go into the operations funds for these countries, and they're going to put it into a trust fund. So over time, the compact funds shrink, and the equal amount that it shrinks by is going into a trust fund. And the idea of the trust fund is that it's put into bank accounts and into stocks and bonds, by heavy hitters, guys who know what they're doing with it. And then it's supposed to grow so that when the compact ends in 2023, it's supposed to have enough of a volume and a core so that it can fund things at the level of the compact now. The U.S. government has also looked at the Government Accounting Agency. They said, with the monies that are going in now and the investments now, there's no way. So we already know that. So we already know that by 2023, the monies that are going in now in this account for the trust fund will not be enough to fund even today for them. So you can see that with the whole structure of this thing, it sort of makes you dizzy. Not enough money now, going in a trust fund that was supposed to be part of the plan, that's not going to be enough money then. So again, very awkward. But why do I share this with you is because you are then going to be working with people and nations who don't have enough money now and probably will not have enough money then. So is this going to end real quick? No. And I think that's something that we have to work with, and that this is not something that's going to go away today, tomorrow, and the logic of it probably suggests that if we don't jump and make that plan, it's going to only get worse. And so it's one where to kind of, I'm glad, we're here kind of at least talking about this type of framework that surrounds the issues that you're going to see on a day-to-day basis. So the FAS, the nation's population, the Chukis have about 54,000 people, Koshai 8,000, 34,000 people in Pohnpei, Marshall Islands, Republic of Palau or Belau. The correct pronunciation is Belau, but it's been called Palau for so long that people kind of go back and forth. And even Chuuk used to be called truck because it was anglicized. Nobody could pronounce Chuuk, so they said truck. So some people still say truckies, but it's Chukis is a proper. And then there's Yappies. And then a lot of these areas, because of the out-migration and moving out, for the reasons we talked about, the populations somewhat are getting smaller. Now, health indicators in infectious disease. What you don't see or you're seeing part of is in these areas, especially the FSM and in the Marshall Islands, there's a lot of dengue fever. They just went through an epidemic. They have cholera epidemics. They have syphilis epidemics. Hepatitis B, which is what Ken and Angela and a lot of folks here work with a lot, that's endemic. Hepatitis C is not such a problem, and we'll talk about more of these later. TB, tuberculosis, is endemic, meaning there's a lot of it, and actually they're getting multi-drug resistant strains. And Hansen's disease is endemic. Hansen's disease or leprosy is endemic in Pohnpei, places in Chuuk, and in the Marshall Islands. So you can see that Did we take care of health care? Well, this sort of looks like a third world country to me. And so, I find that interesting in this way. And one thing about the TB thing that, people don't like to hear this, but, when you get drug resistance, tuberculosis, and, you're going to have to deal with this as caseworkers and so forth. When you get drug resistance, a lot of it is because you identify a case, but the person that you're treating takes partial regimens, you can't find them, you run out of medicines and those kinds of things. So they develop the resistance because they're taking part of the time, and so the bacteria become smart and they become resistant. And when you really think about it, why should, what happened there? Why was there a lack of drugs? Who didn't send them drugs? Why was there a lack of a program? So something, when you hear the word, in my mind, drug resistance, part of it, the issue was that there wasn't an adequate supply of medication and an adequate outreach program, which is not truly a technically difficult thing to do. And so part of the failure you can see is the planning part. They should have never run out of medications. They're actually quite, the base drugs are actually quite cheap, and I see the first person who heads up a lot of the TB from the Department of Health is here too. So that's one where Dr. Glenn Wasserman's in the audience. But it's one where, there might be people who take issue with that. But you can see something as simple as that of drug resistance. It's sometimes we create that. It's our impact on something that maybe shouldn't have happened. We didn't create the TB, but we perhaps helped create some of the resistance. And why I bring that up is, of course, then people will look at the Marshallese and the Chukis and so forth, and they'll say stuff like, you guys created a drug resistance program. You don't know how to run the programs. You're inept at running your own programs. It goes a lot deeper than that. And just, again, I wanted to share that story. Now, one of the things to show you some of the depth of the problems is, this is a shot, and some of you might see this, but this is from an island called Ebi. And Ebi is an island next to the military base, and there's 10,000 people who live on this island, and they're not allowed to live on the base, but they can move in, they do a lot of the job support at the military base. But just to show you, when we talk about health, and to underscore the depth of the need for infrastructure, is the reason that they have these buckets here is these folks go to the military base, which is part of their native land, to get enough potable water. On Ebi Island, up till even, it occurs now, we're talking 2000, what is this, 2012, thank you. They run out of water. And how core is water? How core is fresh water to health? I mean, that's Public Health 101. Public Health 101, and so you can imagine, they don't have water, drug-resistant medication, and so why is there cholera? Why is there typhoid? Those are all water-based disease. Maybe some of the cleanliness factions, they don't have enough water. There's not enough infrastructure. What happened? What did happen? Compact, what happened? And so you see, I'm going at this ad nauseum, but it's one to kind of, I think, make that point. And so the other health outcomes, infant mortality in the Marshall Islands, and we talked about car seats and people going back and forth. And so in the Marshall Islands, 4 times after the United States, Republic of Palau is 4 times out of the United States. FSM is about 6 times out of the United States. And some places in the Marshall Islands, the outer islands, is about 9 times out of the United States. So, no country should have that kind of infant mortality. And again, it's very third worldish. So what's the problem? And so when you see a lot of folks come and get on the plane to deliver their kids here, part of it is to ensure that perhaps they get to be U.S. citizens and that. But the other part of it is maybe their systems need the development to do that. The longevity, you can see that in the United States, we live to 77, 78, 79 now. In the Marshall Islands, you can see the longevity is a lot, entire states of Micronesia, so you can see the longevity is less. So all the health indicators, infant mortality, longevity, health care, and the things that are supposed to be happening, there's something not happening. And so that's, that I think so to me, more of the paradigm is, as case managers and so forth, is to try to get why is that, and to try to work with that. Because I think what we sometimes do, and I do as a physician all the time, I see someone with Hansen's disease. Okay, what medication I'm going to give this guy for Hansen's disease? And I then look through the armamentarium and then try to fix that. But you know what? They're still going to, the Hansen's disease is going to keep coming. The TB is going to still keep coming. So I believe all of us have to step back and say, okay, what is my larger role to help figure this out so that we don't get caught in this wheel? And then malnutrition, there's still vitamin A deficiency. There's the suicide rates in the adolescents, for those of you who work with mental health and behavioral health, the suicide rates in Marshallese adolescents and Chuukese adolescents, it's some of the highest in the world. And so even from a cultural standpoint, you can see that there's a lot of behavioral issues that go on as well. So other health indicators, 50% of the people over 50 have diabetes mellitus. And this is true not only the Marshallese and Micronesians. If some of you don't know the demographics, according to the World Health Organization, as you know, the Pacific has the highest incidence of diabetes and obesity anywhere in the world. I mean, it's not a good first place, but we're talking about Samoa and Cook Islands and Marshall Islands and so forth. But, you know, Guam, all of that. So obesity rates in some of these areas hit 70%. And so, you know, again, you as workers, you can see how that plays out in heart disease and all these other things. But it's true of the Marshall Islands. And why I let you know about the entire Pacific, even in our native Hawaiian population, very high. Polynesians, Micronesians, Polynesian, Micronesians, and Micronesians, very high rates, obesity, diabetes, and all the associated things that go along with it. In the Marshall Islands, 75% of the hospital days were from diabetes, 50% of men and women were overweight, increased ischemic heart disease increasing, strokes increasing, all linked to this. Smoking and ethanol is high, cancer is increasing. So I showed you in one slide how infectious disease are increasing. Then you see how non-communicable disease are increasing too. So they have the double whammy down there. Both ends are increasing, and you see the effects on both ends. So nuclear weapons testing and, you know, the radiation. So there are a lot of testing above ground. So when we tested our weapons, we chose the Marshall Islands because it was far away. And, you know, many of you have heard this. But there was a lot of testing that was done. And it wasn't like digging a hole and you know, like a lot of places. You know, when the French tested in Bora Bora, at least they dug a hole and exploded their nuclear weapons, and they weren't as big as ours in French Tahiti. But when we tested above ground. We wanted to see, well, what's going to happen if we explode this in the atmosphere and above the ground? And we didn't test small bombs. We were in this Cold War with Russia, and so we exploded big bombs. And so the Bravo shot, which is the one that we worked with at PHRI and its effects, by itself was equal to 1,000 Hiroshima bombs. That was one bomb. And then the total yield of all these bombs together was equal to 7,200 Hiroshima bombs. So a lot of folks say, oh, there were only 68, 67 bombs tested. Now look at this. This is what it yielded above the ground over a chronic period of time. So a lot of radiation was released into the air. And of course, you can see what, if you were Marshallese, what you might think about this. You know, you go, interesting. So it irradiated inhabitants downwind, and this is a very sad story. And you know, probably some of you have heard it when I've talked before, but when the Bravo test went off, the one that was 1,000 times the Hiroshima bomb, we knew the wind was blowing a particular way, and you know, the people on Rongelap and Uterik and some of the people downwind, though we knew it was blowing that way, we didn't evacuate them. So the cloud went right over and dusted them, just boom, fell all over them. And you know, radiation is associated with 26 different types of cancers, and you know, and the other thing is, we didn't test in islands that were uninhabited for thousands of years. We went to islands that were ideal for us to test in, and those places were all inhabited. So we told the people, can you move so we can test, essentially? It's for the good of mankind. It's like if I went to Kauai or Molokai and said, or Kaho'olawe, and say, can we test over here? Because, this is an ideal testing site for us. So we told them we're going to move right back, and, it didn't quite happen that way. And so the National Cancer Institute report that just the testing alone would cause 530 excess cancers above background. And then there was another 2010 NCI report which said this is probably more in the order of 300, 250. But the point is that it created a lot of cancers. Why do I go into this a little bit? Because some of the cancers you see may have been, I'm not saying they all have been, and probably a lot have been caused by smoking and hepatitis B and, junk lifestyle and, everything else that happens. But some of them might have been from the nuclear testing. And so when Basic Health Hawaii and the state says, you know what, we're going to cut you off from chemotherapy and cancer and those kinds of things, what does that mean? Because I can tell you from a pathological, a cell study, if someone has lung cancer from smoking or from radiation, there is no way you can tell the difference, none. Or hepatitis B or hepatitis C causing, liver cancer, or someone that is caused by radiation, you can't tell the difference. There's no way to tell the difference from a standpoint of looking at the cells, other than maybe you can see that they have hepatitis B. But let's say they have hepatitis B. What if they were got radiated too? Is that a double whammy? It's kind of like if you smoke and you were radiated. Which caused it? Maybe a little of each. So the compact impact: poor health and education persists. The economic development is challenged. The large out-migration, which you see, and the actual migration patterns, I'm careful to go back and forth. Now, just some of the numbers. About 20,000 compact impact folks are now in Hawaii, Guam, and the CNMI, the Pacific. There's 9,000 Marshallese in Arkansas, just Arkansas alone. And there's a story behind that, the 2-second story. What time is it? I'll give you a 2-second story. The reason they're in Arkansas is there's a chicken processing plant there. No, this is a true story. And when it's Tyson chicken. And when they were doing chicken, they were trying, everybody tries to look at the most economic way to process chicken. And so they were hiring a lot of people that were illegal from Mexico, and they got busted. There was, cheap labor. And so they said, where can we get people who not mind doing that kind of work for cheap? There's this place called Micronesian, and they can come in and out, and they're legal. So they initially brought in the initial workers to work. They found out they were good workers and all this, and the folks from the Marshall Islands and other places start bringing you their families. That's the way. So they bring the folks in, and so after a while, you have this huge community that started off with economic reasons and Tyson's chicken and all those kinds of things. But they're interested. There's 4,000 Marshallese in Costa Mesa, California, and then there's big amounts of Micronesians also in Texas, in Seattle, in all different places now that where they're moving from the compact impact because they can move. And also, I want to emphasize that the compact impact is also an impact in Guam, which is a territory. So they're moving to Guam, which has higher standards. They're moving to the CNMI as well. So the 2000 census said there's 8,725 Micronesians. I don't know how they coined that, Micronesians, in Hawaii. But it's now estimated that in Hawaii there's about 15,000 to 17,000 folks from the compact impact nations, and I think this is probably a little bit more accurate. The key drivers: economic opportunity, employment, medical, and subsistence. And a lot of, we talked about this, why they're here. We talked about why they're here. And one of the things that you'll already see is that they have heavy disease burdens. They're going to have some illnesses that you're not familiar with, and many of the physicians here aren't familiar with. Only a handful of people have ever here have seen Hansen's disease. I'm familiar with that because I lived in the Marshall Islands for 10 years. And Dr. Wasserman can tell you, not a lot of doctors are even familiar with tuberculosis. It's something that was supposed to have been stamped out a while ago. And so they have very particular programs and doctors who deal with that, as they do with the Hansen's disease as well, because it's not really common. Not very many people have seen typhoid and cholera. So when they come in, part of it is as case managers. If you see something strange or some case, it's probably behooves you to kind of go figure it out. And if you're not immunized, there's not very many doctors now who have seen whooping cough and actual measles, those kinds of things which you're supposed to be immunized against, because in general the United States has, with their immunizations and so forth, been able to quiet down. So again, as case managers, you probably will see things that you have to have some awareness of. And so they say, I got this spot on my skin right now. I don't feel anything. It's numb. Could that be Hansen's disease? You call Dr. Wasserman and you go, hey, I think, but it's not to be critical of the patient. That's not the point. It's to get them treated. And just so you know, if someone has Hansen's disease, people will freak out about that, right? But it's very hard to get. You have to live in a crowded situation for a long period of time, and think about, Father Damien. He was in Kalapapa hearing confessions this close. He got it, but it takes a long time to get it. The idea is you have to be in close quarters. Crowding is bad. Close proximity is bad all the time, and being a little bit immune depressed. And so if you're diabetic, not good nutrition, those are the guys who get it. And that's why some of these populations tend to get it more than others. And that's how it spreads. So as caseworkers and so forth, you're not going to get Hansen's disease by, even you can hug them and you're not going to get Hansen's disease. So, that's just one of the things, and you get it from poor living conditions, language, and cultural barriers. Okay, so communicable disease among FAH migrants have high rates of hepatitis, and hepatitis B in particular. In the United States, the carrier rate means people who have hepatitis B viruses that they're carrying around. It's about 1 to 2%, maybe 3% in some areas. In the Federal States of Micronesia, it's 12%. In Marshall Islands, actually it's about 15 to 16%. And Republic of Palau is 12 to 15%. So it's just to show you that the rate of carrying hepatitis B is a lot higher. One of the reasons that it's pushed back in the U.S. is because we have good vaccination rates of hepatitis B vaccines. But the other thing, it comes from mother to infant, so it comes from a lot of its close transmission with folks who aren't immunized and who are carriers. So they have high rates, and so it's something that Ken and many of you, Angela, and lots of the folks in the room, that's what you focus on is hepatitis B. Again, why? Liver cancer, cirrhosis of the liver, transmission, all those types of things. TB cases, and it used to be the new TB cases, the largest amount of TB cases used to come to Hawaii from the Philippines. There's a lot of Filipino immigrants as well. And one of the things about the TB cases now, and maybe Dr. Wasserman can speak to this a little bit more, but a lot of TB cases are not coming from the Pacific areas. Hansen's disease, Federated States Philia Association have the highest, 94% of the new cases in 2008 from the Freely Associated States. And again, used to be the Philippines. And now, so you can see the compact impact is not a small impact. And the total, that was provided actually in 2007, there's different figures now that 900,000 was costs to Hawaii were just from communicable disease services only, not even non-communicable disease services. These are just, and this was in 2007. Now, non-communicable diseases among Freely says the data is lacking. They suffer high morbidities. There's about 110 people on renal dialysis and 160 on chemotherapy. Now, of course, why is this an issue? Again, if these many people are here, and the numbers are probably higher. The numbers are probably higher. And Basic Health Hawaii, remember, the stance of the governor at that time was, we're cutting you guys off. So, what happens to these guys? There's something, right now, Basic Health Hawaii, because there's been injunctions put against them, they can't do that right now. But the point is, when you have an impact that hasn't been studied, everything that I'm talking about plays itself out. And so you have people up here who come for better health care. They don't have dialysis units down there and so forth, or they're not efficiently run, or, and all those types of things. So they come here and then you say, well, you really can't be on Medicaid because the federal government says you can't. Hawaii picks it up, and Hawaii says, we don't want you on Quest anymore. So it's this revolving thing. And I guess, I keep saying this, because I'm looking to all of you as case managers to help solve that, however we can solve that. And, and on that. And then one of the things that happens too when we're talking about, just to show you about policy reaction. So one of the things that just happened in the last 4 months, and this is in real time, part of our federal, our federal presence in, this is Senator Inoue's office, this is Senator Kavika's office, this is our representative's office. They recognize there's a huge impact of dialysis and all this in Hawaii. So what are we going to do about it? So what do you think the reaction is because there was such an outcry from the people in Hawaii? It wasn't a moral reaction. The kinds of things that were coming out of these offices because of the people in Hawaii were like, they shouldn't be able to migrate. You should make them build their own dialysis units. But let me tell you about building their own dialysis units. It will, in Hawaii, it costs about $50,000 per person year to run a dialysis unit. Down there, because of labor costs, it'll cost about $30,000. Remember how I told you about the $128 per person per year? We weren't going to give them new money. We were expecting them to build a unit. Not only do they not have the money, they don't have the infrastructure, they don't have the training, and that's what was coming out of our congressional offices. But you know what they were reacting to? The people of Hawaii being angry. So that's why part of the solution is to understand that what we say, they will react to. And I don't know if, and I have a little bit of side, but and I mentioned this in other talks, the kinds of things that come from Hawaii's people, and I'm talking about Native Hawaiians and Filipinos and Caucasian and everybody, Micronesian cockroaches go home. You don't belong here. That's the general sentiment because of how they are seen as using our resources. And so you can see the compact impact and unintended consequences are not minor. They're major. And how we play it out, our congressional offices pick it up, and so forth. And the other thing I can tell you with the congressional offices is that they said, we should take some of their compact money and give it to Hawaii. So the compact money that they get is this big. You take the money from them, what's going to happen to the rest of their services, education, everything else? So all these things that you go, none of this makes sense. It's a gut reaction to a bad problem that nobody studied, and now we're wheeling and dealing and trying to figure out how do we go forward. So socioeconomic indicators, average household size here in Hawaii is 6, but one of the things they get hammered for, in some places up to 17. Micronesians are used to living together. They don't jam in people because they necessarily have to. They live in, because in the traditional Micronesian setting, your kitchen, where you play is outside. Where you sleep is the hut. So the outside is everything else. So when they come together to sleep, all the landlords and everybody gets upset. But to them, that's how they do it. All the kids, everybody packs it up. But of course, then where do you play and where do you use the bathroom? But the point is that it's not incongruent to them to then be crowded. It's not like if you go in as a case where they say, don't you know that it's so crowded in here? And I love to sleep next to my daughter and son and all this, because then I can see what's going on. But it's one where that level of thinking, it's a different cultural mindset. And the other thing about being crowded, certain things that bother us a lot, like having ukus in the hair. When I lived in the Marshall Islands, I lived there for a long time. I'll tell you what, as a physician, not only did I get ukus a lot, my family did. It's not a big deal. And they will often turn to me and say, why does the state and the schools get upset when they find we have ukus in the hair? I must admit now, having that, I have a problem with that too. Because I think it represents, oh, you're dirty or something, but certainly it doesn't kill you, it makes your head itchy, but they have, as you know, tradition is the mothers and so forth would sit the child down or the husband down and they pick the lice out of the hair and smash them, so it became very much a nurturing thing. But it's that kind of traditional thing, so understanding that if you're sent out as a caseworker and so forth, this person has ukus in their hair and they've been sent home from school and they're the pariah now. I've had lots of stuff from, I had hepatitis A, I had ascariasis, the worm and stuff. It's one where when you eat down there, but you know what? Totally treatable. It's hard to see worms coming out of your butt, but when you think about it, totally treatable. And some things you get that oogie feeling. It's oogie because we think it is, but from a relative health problem versus diabetes or tuberculosis, you know what? It's nothing. It is nothing. And so I guess that relative, and that's my 2 cents. The federal states of Micronesia now, unfortunately, are also overrepresented in the homeless shelters. They fill quite a big part of the homeless shelters, and they also fill quite a bit of the shelters, like KPT and so forth. And as you know, when I was growing up, the people who lived in the KPT were, the Samoans, and they were the Filipinos, and Native Hawaiians before that. That's who lived in the housing. Now it's, and then it's evolved, and then it was a lot of Vietnamese. And now I can tell you it's Chukis, Marshallese. That's who lives in these housing. But one of the things that I also want to share with you, and it's a point, and Davis and I and others did, actually did a chapter on this, and we looked at that. And, a lot of people say, aren't you ashamed to live in the homeless shelters? And aren't you ashamed to live in KPT and so forth? It's low-income housing. And they look at us and go, when we're in KPT or the housing, it's a community of Chukis, a community of Marshallese. We cannot get into your housing. It's too expensive. So it's not dystonic to them. That's their home. That's their village. If you go live in Hawaii Kai, you ain't going to have one, it's very expensive. But the other thing is, it's hard to have that kind of community there because you need a whole block of, Chukis living together. And in fact, one of the things that they've done is, they went into a lot of areas that are, and you know this as caseworkers, a lot of areas that were really cheap. So Ojai Street in Wahiawa was known kind of as a very heavily drug dealing area in Wahiawa. And what happened is the Marshallese found out that it's really cheap over there. So they began moving in, and now they occupy a lot of it. You know what happens with the drug problem over there? Gone. So you can see compact impact has a lot of good impacts, but it has bad impacts, other things like that. So it's one of these things that when you go to them, kind of look in that broader sense of, why are you in the housing? And they've also found out that, and we know this, the strategy to get high on the list in the low-income housing is you go into the homeless shelters. So if you're in a homeless shelter and you have kids, your priority goes up on the list of, who goes in the homeless shelters. So they've sort of figured that out a little bit, and I think you guys all know that. So it's one of, they're not stupid by any means. In fact, they've got their systems going of how this thing works, and I think to take advantage of the people who kind of know those systems. And so language access, limited English proficiency, we need a better census, a lot of language areas, and many of you have to deal with that because, as we heard with this car seats, if, it was mentioned that, the policeman comes and he's trying to talk about car seats, they can't even discuss the car seat because, there's a huge language area. So one of the things about language access and cultural access to that is to somehow develop those kinds of things and develop those tools. And one of the things I've seen that to me is kind of, I must admit, is an insult, a little bit of an insult, is that when the hospitals look for translators and so forth, they want family members to translate, which is, good, but of course, as you know, family member translators, people who aren't trained in translating, especially medical translating, sometimes it's a real bad idea because you don't know what they're saying, and sometimes they don't know what they're saying back in, when they translate, but so it's a bad idea. But the other thing about it, and to me the insult is, everybody expects the Micronesians to come out with a heavy level of translation for free. Who else translates for free? And so, and I've heard the Micronesian people can't even provide their own trained translators to this, and they're creating all this health problem. I say, how many people do you know that translate formally for other groups, translate for free? So, so it's that kind of thing that, just to think on that, sometimes you get professional Japanese translators. And, there's people who actually do it out of the goodness of their heart, but I can tell you from working with the folks who can do it and do it competently, they're stretched, and they're called all the time, and they're just saying there's got to be a better way to do this. And we talked about this, and what is the actual compact impact, and just so you know why the congressional offices and why the people of Hawaii cry foul. One is that Hawaii estimated $90 million in annual uncompensated care from freely associated state migrants. And this was way back. Now, in 2010, they say it's 100 and, I've seen different figures, but it's about up to 114 million. That was what the uncompensated care is. There was the federal government was asked by Hawaii and a lot of other states, they said, we're having so much of this compact impact. Can you help us with some of the dollars? And so they asked actually the U.S. for Guam, the CNMI, and Hawaii said, can you provide $100 million to each of these places to alleviate some of this problem? This was years ago. And what the U.S. government said, the federal government said, well, we can't do that. We don't have enough, but we can provide $30 million. But we're going to have to divide the $30 million 3 ways. So part of it, because of the impact in Guam, has to go there. And so the share of the $30 million that we get is about $11 million a year. But let's say the impact is $114 million. That's why our congressional guys go, okay, what is the solution? Federal government says they don't have money. State government doesn't have money. Maybe stay home is the answer, or build your own dialysis machines, whatever it is. But it's one where it's a difficult problem. But just to show you why there's such a heavy reaction to it, it does cost a lot of money. And I had the fortune to be able to work in the Department of Health for 5 months. Very short 5 months. I did it 5 months. But when I was there for 5 months, I worked really closely with the Medicare and Medicaid folks. And what I found out was that in the year I was there, the Medicaid deficit was $224 million. You know what part the Micronesians had of that? 16 of the 224. So when people cry, Micronesians cause a big cost, yes, they do. 16, 20, 25, that's not a small cost. But put it relative to what the actual cost is. And so why are you targeting these guys? It's everybody's problem. I'm not saying it doesn't cost anything. It is a big cost, but when you put something sometimes into a bigger schematic, you can see, I understand. And the dollars now are not, refunded and so forth. And a lot of the government offices actually did try to approach through legislation, putting back in the federal 1996 law that says you can get into Medicaid, but every time it's shut down. In fact, in Obama's health reform, I know that several of the offices tried to put the language into the reform language. It was taken out. So I don't want to leave you with a message that they're heathens and they're not trying, but everything that's being tried has been, pulled apart. And so it's one of these things, how do we help to solve this? And we are trying to do this. And one of the things about Basic Health Hawaii, where it is now, and can somebody give me a time check? What is that? Let me use this as my last slide, and I'd like to just enter into dialogue because I want to make sure that we leave time for questions because I can go into the diseases and other charts and so forth. So the health crisis right now, where we're at. So Basic Health Hawaii now is in place. But remember, in a previous administration, they were trying to say because of these costs, it wasn't trying to. I don't believe it. Nobody's trying to target anybody. Nobody's trying to nail anybody on the head. But they said because of these costs, the state of Hawaii can't do this anymore. So they were going to cut the freely associated states off from Basic Health, the Quest program, and they were going to build something called Basic Health Hawaii. And the plan was to save $20 million for the state. So the first iteration of it was they didn't do any process planning. They didn't tell them about it. It was implemented very quickly. So the first iteration was blocked by the federal judge because he said, you didn't put in your own administrative rules. You implemented this quickly. There was nothing gone out in language. The people had no way to reply. so you can't do this. So that's why when you heard Basic Health Hawaii was trumped by the federal judge, it was because the the state government didn't put in its own rules. And so they said, okay, we will do that. So they went and they had all the hearings and did things in language and so forth. I was, in part of that, and I can tell you it wasn't done well, but be that in may, they did it. Then they went to the federal judge and said, okay, can we do it now? And then, of course, the Lawyers for Equal Justice, and I know, is Dina in here? But several attorneys representing a lot of the microneesians said, we want to make this into a class action suit. And so the reason that the federal judge held it up again, and this was just recently, and he said, State of Hawaii, you can't do this. And the reason he held it up again was he said, because it's a civil rights violation. You are targeting a particular race of people. You can't do that. You have to then, if you're going to do that, it's got to be for some other reason. It can't be because they're Micronesian or because they're compact impact folks. There has to be some. And so where it is at now, so you know where this thing is heading. The Micronesians, Governor Abercrombie has a choice. He has a choice, and so does the state legislature, but it's pretty much Governor Abercrombie's choice. He can either appeal the federal decision and let it be appealed formally in the higher courts, might even go to the Supreme Court, or he can say, I choose not to appeal it. If he chooses not to appeal it, it stops. And then what happens is Basic Health Hawaii sort of goes away. When that was brought to Governor Abercrombie, he says, I understand the plight, and I truly mean this. I know I believe he cares. But I'm going to let the appeal go forward. So it is being appealed. Now, this appeal is not without implications for everybody. Because if you do this, and Hawaii's going to save money, you can't target a race. So Quest is going to look like the Basic Health Hawaii plan. And what that means is everybody gets truncated version of state Medicaid. So you only have a certain amount of visits. Everything is cut back because you can see compact impact is not a small impact. The political policy and everything's all tied into this world together, kind of like the body is. And that's it. So I will stop here because I've kind of gone on, and I'd like to kind of address questions whether medical or about this, and so that we have a chance at dialogue. So and questions or other viewpoints, please. I love other viewpoints. It's always a good thing. So if I may jump in. Questions, say, baloney, it's not true. Other sites, I don't know how this works.
You have an audience on Maui. Oh.
You did.
How are you? I was, do this.
Hi, Neal.
Hey, Barb, how are you?
Okay, retired.
No way.
Anyway, my question is, with the water table rising in a lot of these islands, and we know that it's very, very flat, especially in the Marshall Islands. The concern is, how are they going to grow their own food? How are they going to continue living there? Because many of the atolls are very small, right? And is there any kind of plan that that's being developed to look at this particular issue?
So Barb's question is as usual, very complex but important question. So a lot of these Micronesian areas, like the Marshall Islands, the average elevation above sea level is 6 feet. So, it's going to be very impacted. It's not a high island. There's no mountains and streams. And even in Palau and other places, it doesn't get very high. Palau has, some other island is a lot higher than 6 feet, but some of it is not. And so a few inches of, water rise is a huge deal. And then, of course, it starts flooding taro patches and so forth, and the taro and other, the way the plants grew up over years, they don't tolerate, frank salt water. So it has created a big problem in many ways that's, being studied. And so the water rise actually, people are actually out migrating from there because their taro is getting flooded. They can't grow it anymore. They're finding out that the way that their subsistence lived, because not only does it change taro foods, but it changes the ecology of coral and all of that. So it's one that is a huge problem, and it's another reason they're going to out-migrate. That's another reason why they're going to need USD type foods, which isn't going to be very cheap for them. So, a lot of this is happening. But I think one of the things that I wanted to speak to, which ties into this policy thing, is that the climate change, the Kyoto Convention, and there was then a Copenhagen Convention that was trying to speak to this whole idea about climate change. And again, climate change in a nutshell is there's a lot of gases that go into the atmosphere, including carbon dioxide and methane, by things that we do, cars and industry, and just the methane from actually the poop from cows is actually, I found out, is a big, but it's mostly industrial kinds of things. But when it goes into the atmosphere, it keeps the heat in, it keeps this layer in, and then melts the ice caps and so forth, and the water level rises. So when they look at that, they say that's a human cause. The biggest causes are the heavily industrialized countries, us, China, and other places. The one country that hasn't joined the Kyoto Convention, the United States. You can see that the policy, and of course, the United States' position on it is that, well, then we'll have to regulate industry more, and that is not a constitutional thing that you can do because you start reaching in too far into industry. You know this one. So, do I claim to know, U.S. policy? And I'm no constitution anything. So, but it's one of these things of when the policy action, whether it's compact or those kinds of things aren't addressed, the problem continues. The small guy gets wrapped, and you're going to see the effects. Compact impact. They can come over here. But, in a more immediate sense, they're being driven from their homes by something we do. And the other thing that the U.S. hasn't joined in, and many of you know about this, you're all health workers, is the Tobacco-Free Convention. So we think Tobacco-Free Convention of the world, climate change of the world, everybody else joins, the United States doesn't join, but it's all the idea, again, I'm not bashing anybody, it's U.S. law. It's kind of how far can you reach into industry and regulate industry. So there's a whole side of that, and I don't claim to know the answers, but that's why, you saw in this new election that I think it was Gingrich that they showed him saying that, I don't understand why we haven't joined the, water level, the climate change thing. And then when they interviewed him, he said, I don't know why he said that back there, because he has to take the position you cannot reach into industry. So, long answer, very difficult problem, but everything ties to each other. But again, I turn that over to you because that's a voter, people problem, and you've got to deal with it. And if you don't, it just goes round and round and round. Other questions? Anyway, did I answer your question, Barbara?
Thank you very much for an excellent presentation. I certainly learned a lot about the history that I didn't know before. Last month I did a training on non-traditional type of employment, and I've always been one to try to think outside the box. I know this sounds a little far-fetched, but well, in addition to working, I have several hats that I wear, and one is that I work for the Access to Recovery program. We received $11.4 million from the federal government. And in just February and March alone, I got a large number of Micronesian people coming to me for assessments. And I made referrals for them to one of our network providers who provides computer training. And so they were taking advantage of that. I think it was maybe word of mouth or whatever, but they just, around February and March, I started getting more and more Micronesian people coming for to take advantage of that service. We're moving towards a computer age, and this is just going to be, it's already presently here in 2012 that every business is going online in some shape, form, or fashion. My point is, since we have so little traditional jobs, I'm thinking about non-traditional jobs. In addition to being a mental health counselor, I'm also a voc rehab counselor, which is my passion. And I'm thinking about non-traditional jobs. I even offer to provide to volunteer my services to help to get them on the path, or just give some direction, because at one point in my life I was in a position where I needed some direction, and I got it, and as a result of it, I just kept snowballing till I got to be kind of a multidisciplinary professional. So I just say that to say, thinking outside the box. When we look to government and we look to other people and agencies for things, there are non-traditional jobs that I think that we could maybe point them in the direction of. I don't know how that will work. And if we have one more person wants to speak, and then I see that the thing is opened up for our sites as well.
Angela, since we're very close to, we're actually almost over time, can we ask the neighbor islands and other sites if anyone has a question?
Yes. Okay, so you can hold the answer for that one. I know Valerie had a question. She has waived to ask the islands for questions. Please, anyone, if you have a question, unmute your mic and use the mic and address your question to Dr. Palafox at this time.
I think everybody's just trying to grasp all of that information.
That's plenty.
Wow.
And I'm just sitting there like, we ain't been on the screen all this time.
Are you directing that to Dr. Palafox? We can hear you speaking.
See what?
You have a question? Anyone? If not, I'm going to pass the mic to Valerie.
Molokai is here, and we'd like to ask a question.
Somebody has a question.
Go ahead, Molokai.
Dr. Palafox,
ahead,
thank you for
Molokai.
talking to us. Thank you for talking to us today. Could you please address if folks are coming over with addiction issues, and are they receiving effective substance abuse treatment when they come, and what drugs are they addicted to when they come here to Hawaii? Thank you.
So, as I understand the question, Molokai, is a lot of Micronesians have drug addiction problems. Fortunately, a lot of them do not come with the drug addiction. They come from very poor areas, so they don't come drug addicted. But you can imagine the poor sectors anywhere in the world, they tend to pick it up when they're here. So amphetamine use, other drug abuse is becoming more, but it's when they come here, and like anybody else, you're poor, you look for things to do, and on and on. They do tend to have a little bit of a high smoking rate, and they have high alcohol use rates. And I must say, and again, this is sometimes the alcohol use rate is irresponsible, but as far as drug use, and I think if you mean methamphetamines and heroin and marijuana, that is not a true issue down there, those kinds of addictions. Alcohol is becoming more of a problem, and certainly tobacco is.
Can you mention about betel nut and mixing tobacco with betel nut, which a lot of people are addicted to in the...
Betel nut.
Okay, so betel nut is it's a seed, and it has an alkaloid in it that if you chew the betel nut, I've taken betel nut. It gives you a buzz. It just gives you a buzz. A short-term buzz lasts about, depending on what it is, and maybe Davis can talk about it more. But it gives you this buzz, and it goes away. It is addictive in the sense like anything else. When you chew it and you get the buzz all the time. Some people chew it and it makes your teeth red, and so forth. But what's happened and that used to be a semi-traditional thing in these places, and certainly it's in Nepal and India and every place else. But currently what they do now is they mix other things with the betel nut. So they'll take the cigarette and they'll put it in the betel nut and they'll chew it, so they get the tobacco effect as well as the betel nut effect. And so it makes it more carcinogenic. So is that an addiction? I mean, it's hard to get betel nut. I mean, they have stores here now that sell it. But I think the bigger impact is not so much the betel nut as it is the tobacco and the betel nut. And the people who push it, of course, are the tobacco companies. They know these things, so they'll sell it as, something to chew with it and so forth. So to answer Ken's question, Chukis don't chew so much of it. Marshfies, it tends to be more Yapis, Palauan, Chamorros are the big chewers. So even knowing your population, it is entering somewhat into the Chukis and Marshfies, but very small amounts. So the big chewers, the heavy, heavy chewers, are actually not here. And so it's just something, and then, so if that's considered an addiction, but I think it's an addiction, but it's actually hard to get the betel nut. You have to kind of find it and so forth. And of course, when you have that kind of habit, you tend to then smoke more and chew tobacco more and those kinds of things.
Well, it looks like we're out of time. Do we have one more question here?
Hi, Dr. Palafox. Michael Green, Hawaii Tumor Registry. The comment you made about the temporary restraining order and then the appeal that would have to move forward and the equity.
Okay.
So that says Quest would then be changed to basic health. So that would mean people on Quest would have a limited number of visits and all of that, and wouldn't cover a chemotherapy regime or radiation therapy or dialysis or what, so, you know what I'm saying? So I guess that's when it's going to get corrected. Is that right?
Well,
if that happens, I mean, if they have to move forward like that, then that's going to have an impact, definite impact on more than Micronesians.
Yes, and I think it's just to consider that, but it's one certainly with, as you say, the cause and effect, and so certainly everybody there might be such a cry out that they might say, you know what, let's not have basic health Hawaii in any form. And so, but then the question that everybody's going to have to answer, well, how are we going to save money? This thing's costing too much, because the whole thing about basic health Hawaii or creating any of these programs is how do you save money? It costs too much. There's too much. So to answer your question, that's why it's so complicated, and that's why it makes you really think, if you have to do this, how do you do it in a sane way? And really, it's about fixing the health system and how we think about it. So because obviously I would think that, let's say if it goes forward, it goes to the courts, and it does say you can't do this to one group, so you're going to have to put basic health away on everybody. No person in Hawaii is going to stand for that. You're going to have an outcry, but my thing is, there should be the outcry now, not wait till this thing pushes shove, but it's really, it's kind of like, let's see what happens to these guys. Because, they don't vote, they don't, but
if that applies to everybody,
right.
Then you're not able to meet the standard of care.
That's right.
Then you have all these other issues that will then come from that. So, yeah, I think people should be saying something now rather than later.
And one of Michael's points is really good. I've known Mike for a long time too. He works a lot in the Pacific as well. Is when you have basic health Hawaii, one of the things it says is that you only can get 5 prescription drugs a month. If you're in dialysis and you're diabetic, you're on 8, 9 medications, so you are not going to get the standard of care. So even the basic health of Hawaii people, what you're telling them, you're telling the Micronesian, yeah, but we're not going to give you the standard. To me, what is that? And then the implication, like you say, if you do that to everybody else, you're going to be telling the poor, whoever, you're not getting the standard because, you know what, you're not going to get the standard. So, but the fix is not an easy fix, as you can see either.
Is there a question out there? We technically have until 2, but in respect for your time, Dr. Palafox, we did tell you 1:30. So if you're willing to answer a couple more questions, if you have the time.
I'm good.
Okay, Dr. Palafox is able to answer some more questions. So I understand someone else out there, one of the sites has someone at one of the sites has a question.
Hi, this is Maui. We don't have questions, but I want to just say thank you to Dr. Palafox. That was a great presentation, so thank you so much.
Thank you.
Thank you for being here, Maui. He said thank you.
Should have called Charlotte.
Hi, Neal. I really liked the context of your history and linking it to the political forces. I thought you did that very well, and we don't get that detail that we need, because I've heard you a few years ago, but it's even clearer this time, so you did a fabulous job. But to end this on the solution side, what do you gave us lots of tips as frontline workers, but what do you suggest, kind of recommend the next steps? I know you work with the different Micronesian organizations. What are they focusing on? How should we focus our collective approach? One or two suggestions. You might have had a slide and we just didn't get to it.
I think the biggest thing is, when all this thing came into the United States about immigrants and wetbacks and all that, and became a big policy issue, Obama took a stance on that, and he made a policy decision that we need to address this. And part of what he said in his addressing it, he said there has to be a way that we can formally integrate these people into I'm talking about immigrants all over, including migrants. And so the idea behind this policy was there has to be civil integration and economic integration. And one of the problems, to answer your question, the idea of civil integration means that the people should feel welcomed. They should feel welcome and a part. And so they're going to engage you at a higher level of helping you solve the problem and you solve their problem if they feel welcome. So the first thing is there's no civil engagement. In fact, it's almost the opposite. It's like people have built this wall. And that's why they're even trying to do civil integration between the people who are here illegally. Because then you get them to come out of the box. You get to, help them to solve those kinds of problems. The first thing is civil integration. Then you get the economic integration and, understand those kinds of things. But so to me, the first point in understanding this is that we as a group help with that civil integration of making them not only feel welcome, but helping their plight become our plight and vice versa. Because I think they don't quite understand as well. I mean, if you look on the other side, why are we getting pushed against by the people of Hawaii and Arkansas and so forth? It's because maybe the people of Hawaii and Arkansas don't fully understand the problem either. So it's one of these things of that idea of civil integration. It's philosophical, but it's one as we do our work, and as you hear, there's a hearing on Basic Health Hawaii, or should the governor go forward with this, or what should we do with, Micronesian health care, or overrepresented Micronesians in prisons, all these kinds of things, or the United States government and sending notice offices don't let them come over anymore, to get involved in that. And get involved in a rational way. But it's, I think, a rational way from addressing the dynamics of being a human being and what's happened historically. So, long answer, but I think that's civil integration, because I think you guys are on the ground. You see the patients. You see the people coming with the car seats. And so they can feel that either you're going to be handing them a car seat like this, and oh, for goodness sakes, don't you get the car seat thing, or you can take it into a wider dialogue of, here's a car seat, but I understand that, I can see that you might see someone's overweight and this and that. Let me make a couple calls, and I'd like you to, take your baby who looks really underweight to me. You're thinking that, to get into some of the other processes. So that's, to me, the civil integration that's meaningful, but it only comes from people to people. It's hard as a philosophical construct to be meaningful. So I think that, and then I think, like you mentioned, there's a lot of Micronesian groups that are actually very active, and they're trying to move along. They're finding their impediments, but they're finding a lot of the impediments. I think it's, and especially, I'll tell you, during this election year coming up.
The conference is about to end.
Because it's a hot topic. Hot topic meaning that if they say yes to a lot of these things, the next thing is someone's going to look at them and say, where's the money coming from? I don't know where the money's coming from, so they get in trouble. So, again, another thing with civil integration is to give your legislature
The meeting has been extended by the moderator.
Support to then venture into the shark-infested waters so that you don't end up getting their head cut off or something. And I can tell you this, lots of legislators I know that are really passionate by this and understand it, but they won't touch it. And they'll tell me that personally. They'll go, there's such a heavy case for this that addresses it's the same issues as Native Hawaiians and on and on and on. But they said this one is a hot potato, Neal. We can't. There's money attached. When there's money attached, it becomes and we're looking for election. If we support this, people might think we're taking their money. So you can see it's complex. But it's again understanding that, and then. But I would say those are the two things: civil immigration, but also where you can have the impact is by influencing your legislators that just not only giving permission, say it's important that we solve this. Otherwise, it's only going to get worse for everybody. It will. And so
there's a question from Kapolei.
And also, a caucus office and the representatives and Daniel Inouye's office. Those kind of things.
Hello, there's a question from Kapolei.
Okay, thank you very much. If there are no further questions, may I please just
hello?
Share just a point that I was making earlier. We live in a global economy. It seems like, we're looking to Hawaii and the federal government as rescuers in this situation. We're in a global economy, and we need to look outside of just this state and the government's compact treaty to try and help these people, because it's not really well understood or well known, or either just ignored, that there are plenty of non-traditional jobs out there that people can get. So I would like to get in touch with some of those Micronesian leaders and speak with them and see if they're not interested in trying to help these people to help themselves. There's an old tale about this man who stands on the beach and he's throwing all these starfish have washed up, and he's throwing in one starfish back into the water at a time, and someone walks up to him and say, "Look at all these starfish, do you think you're making a difference?" And he picks one up and he throws it in the water, and he says it made a difference to him. So we have to look at it sometimes from a perspective of outside of what we have here, because there's plenty out there. There's opportunities that are through the roof. And I would like to just help. That's where I'm looking to for my future, and I'd like to help to take some other people with me on that journey. So thank you very much. My name is Angela Smith. And, my contact number, if you want to follow up with me, is 349-1137. Thank you, Dr. Palafox. You've done a terrific job today.
Thank you all.
Very blessed to have had you. Thank you all for coming, and I hope you'll be back next training. We're going to have the organ donors of Hawaii come out and speak to us, Christine Boji, and we're also hoping to have Dr. Kalani Brady join us. Thank you. Thank you, ma'am, for bringing this stuff.
Is there any other way, taking the structural discriminatory issues and the compact impact issues, is there any way to take those things and cluster them in a way to particularize that group without looking at them as a race?
I think it was because the fact that, when we get other immigrants come in, from Philippines, they have their right documents. It also has to do with the documentation. I think that's why he brought up the